going on in this particular symposium, going on in the same strain. We've had a talk on intermittent caloric restriction, a little bit on meal series, etc. What I want to do is take it to the next step, and that is, since compliance is very difficult with different diets, people are so busy nowadays. They don't have time to try out new recipes, whether it's the women or the men, everyone is extremely busy, and then adherence becomes such an issue. So in that scenario, maybe, especially in type 2 diabetics, it might be a good idea, at least sometimes, or some parts of the month or the week, to offer them some kind of snacks. Maybe not a shake, as Shilpa said, because some people don't like shakes, but maybe some kind of pre-made snacks, which will kind of, make them adhere to it, make it convenient, make it easy to carry. And we're going to look at some of the evidence of using such a thing. The other important thing is, we had the 3-meal, 3-snack theory for type 2 diabetes until recently. But today, we have so many drugs for type 2 diabetes that don't really cause hypoglycemia. Except for the sulfonylureas and insulin, all the others do not cause too much of hypoglycemia. And hence, we are not compelled to make them eat in between. Having said that, it is still a good idea to eat intermittently, only so that at meal times one is not so hungry as to overeat. Because you know that if one overeats at any particular meal, the sugars are going to go up. So with that much of a background, I'm going to move on ahead and talk to you a little about partial meal replacements that help in diabetes as well as in obesity. So all of us know these statistics. Diabetes is on the rise and we need to stem it. And to effectively understand and treat it, the food intake, everything has to be balanced, the physical activity has to be balanced, and my talk is focused towards the food intake part. So these are the dietary requirements. Most nutritionists would use that. Now we know that small changes in dietary recommendations in type 2 diabetes, if you use low glycemic foods, that is, don't allow the sugar to rise much, moderately high protein products, some studies have shown that maybe that will help. And I'm going to show you some data also which shows that our carbohydrate intake in India is far higher than what is recommended. And maybe that's where these partial meal replacements can really help us. So how carbohydrates are divided between the meals and during the day are definitely going to make an impact on the blood sugars that are coming up. So this is just a slide to show you that if you space out the meals nicely, the insulin and the blood sugar are in tandem with each other and you have a much smoother control, as opposed to having 3 large meals a day in which you will find that the blood sugars will overshoot what your blood insulin can do, and that's not very good for the overall control. So some plates were already shown by Shilpa. These are some more plates that I'm showing you. There's fast food, and trust me, Indian fast food is as bad as the Western fast food in terms of calories, carbohydrates, and fats. And so it's not very easy to ask a person to snack and not specify what that person should snack on. Because it could be a snack like this, which would just spiral the sugars completely out of control. So another problem is sugar-sweetened beverages, the Pepsis and the Colas, which is on the rise, especially in the metros, and that can play havoc with the blood sugars. So these are some of the recommendations on how much sugar one can take in. Some of you must be aware of that. Obviously, if the person is diabetic, the sugars are to be limited drastically. Now this is, I think, a study that Shilpa has been involved in, if I'm not mistaken, where they have, this is a newspaper cutting, I don't have the reference for it, but you can see here the carbohydrate content across the country. You can see that 75, anything ranging between 66, 65 to 75 across the cities in India. And this is far, far higher a carbohydrate intake than what is recommended by any agency for type 2 diabetes. And this is true of the meals and this is true of the snacks. So what can we do to reduce this? Of course, there is no substitute for good dietary advice, but when we ask a person to snack, maybe partial meal replacements can help us in trying to reduce this. So the carbohydrate seems to be the main culprit, as many studies show us nowadays. This is just to show you some common snacks and their nutrient values. It could be a little off here and there, but you can see the calories are high, the carbohydrates are high for one time, and the fats are of course high in the usual thing like a samosa or a poha. So this is just across the country, the different stuff that people eat. So snacking may have positive advantages in terms of weight control compared with 3 major meals a day, as I have already told you. So about the carbohydrate content, when we talk, we invariably come to the concept of glycemic index. I know that there is no 100% evidence that tells us that low GI focus is the way to go, but there is some truth in it, and I do know that the glycemic index keep on changing with what you eat with a particular food and the way it is cooked. But having said that, it is still a good idea to at least have some attention to the glycemic index vis-a-vis the glucose, and you know how that is calculated. So it's important to keep that in mind. So there are recommendations by the ADA about total carbohydrate versus glycemic index. So there is A-level evidence to show that the total amount of carbohydrate is more important than the glycemic index, and there is B-level evidence for the contrary. And there is C level of evidence showing that individuals receiving fixed daily insulin doses should try to be consistent in day-to-day carbohydrate intake. So the expert consensus is that carbohydrate and move fast together should be around 70% of energy intake, but the metabolic profile and need for weight loss should be considered when you are putting this into place. What about the proteins? All of us know these are the regular guidelines. The long-term effects of diets high in protein, higher than what is recommended, is not known, but such diets may produce short-term weight loss, as we have discussed about ketogenic diets, high protein diets, low carb diets, etc., and improving glycemia. About fats, the less the better, because fats were a culprit until a decade ago, and now we know that fats are, except for the absolutely saturated fats, we don't know. We know now that fats may not really be the culprit, and carbohydrates are supposed to be the new culprit. So the ADA recommendations on fat, the A-level evidence is that less than 10% of energy intake should come from saturated fats. So other than that, we don't have any other major evidence. This is a study which we had done a couple of years back, a very small study, just about 17 to 20 patients. And what we did in this study was we gave extracts of proteins just enough to make each meal to have a particular ratio of carbohydrate to protein, which was approximately 4:1. Because we know that, as I showed you earlier also, that the carbohydrate content of food across India is very high. So what we did a small experiment where we gave sealed packets of protein extract, which could be just added to the chapati or whatever it was, and the ratio was completely made up, and that was done at each meal. And there were 17 people, and these were the criteria and inclusion and exclusion criteria. It was a very small study. And what this study showed was that there was a statistically significant percentage reduction in the waist circumference and the waist-hip ratio as compared to the controls. And you can see here the plotting of a glucose tolerance test in the cases and controls. And you can see that in the cases that we used a protein extract, when we added it to the food, you can see the beautiful curve of the blood sugar that goes down. And you can see in the controls that it went all the way up to 200. And so it was just a small experiment which showed you that you just reduce the carbohydrate a little, increase the protein a little bit in each meal, and you can find that the level of the glucose comes down. This is another study which again shows you that if you use a formula diet, like either meal replacement or a meal supplement, it is effective in reducing weight and in improving coronary risk factors also. So, a mid-meal snack. What would a mid-meal snack do? For example, breakfast, lunch, dinner is okay, but in between fillers that patients are used to, instead of just telling them to snack and you run the risk of them having, say, a samosa, an idli, or whatever it is, where the carbohydrate content is high, what if you were able to supply a mid-meal snack to patients who can afford it, a pre-made snack which has all the attributes of a perfect snack in terms of carbohydrates, calories, and fat. If you were to do that, then maybe the meal plan would be much better and the spacing would be good. Patients will eat at regular intervals and you might get a smoother blood sugar profile by doing that. So what should I do? Suppose you have to make a snack bar and give it to a patient. What should it be like? I'm not even talking about a complete meal replacement. I'm just talking about a mid-meal snack in between. It should be balanced nutritionally. It should be palatable. Like Shilpa said, people say, don't give us those shakes, we don't want them anymore. So it has to be palatable. You should feel full and it should curb your craving to go and reach out for some other food. And it should not have an adverse effect on the medication that is going on. And most important of all, it should be very easy to carry, not cumbersome at all, well packed. So this would be a good option to improve compliance, adherence, and get to goal. So maybe it should have 50 to 60% of total energy as carbohydrates. Personally speaking, if you would ask me, I would put that down even a little more. And 20 to 30% as fats, and with more of PUFA, and 15 to 20% of proteins, and the calories could be 150 to 200, ideally 150, not more than 150 actually. Maybe this would be a perfect mid-meal snack if one could package it in this way, and there are some available, there might be some more coming in, and this would be an ideal snack which you could tell your patients. So, the last part of what I'm going to talk about is meal replacements and supplements. These are food. What are meal replacements or supplements? Basically, these are foods consumed during meal moments, either a main meal or a snack time, and it is replaced by a certain combination. And this is a balanced, healthy mix of nutrients, usually for weight management, but also used in diabetics to space out the meals nicely. And the weight management that ensues because of this indirectly supports disease management as well. What is the benefit of a partial meal replacement? It is part of an effective structured plan. Patient feels that he or she is on a structured plan and may adhere to it better. The compliance is improved. There is some amount of discipline that sets it. Maybe the nutrition knowledge increases if you teach them to look at the nutrition labels and figure out for themselves what is a carbohydrate, what is a protein, and how much it should be. They might eat better, and most certainly, it's a well-defined alternative to calorie-dense foods. And then they also learn to get satisfied with a particular portion. So they learn portion control. And then, of course, the convenience and ease of choice if you want to give a meal replacement. And some people are actually slaves of routine. They like routine. It all depends on the mindset. So if there is a person who likes routine, then this is for them. If a person says variety is the spice of life, maybe this is a difficult option for them. And remember, these products must be used under supervision because patients cannot use these things indiscriminately. It might have adverse events, and it should be part of a structured program. So to conclude, some of these supervised programs can be used as part of long-term weight loss. They are very good motivators and behavioral tools for weight loss and blood sugar management. Their nutritional adequacy makes them indispensable to LCDs and VLCDs. We talked about LCDs and VLCDs a little time ago, and then meal replacements and supplements are the backbone of such structured diets, and they should always be used under supervision and must be part of an overall weight reduction strategy and not a standalone advice, because many people think thinking this bar is a weight reducing bar, it has some medicinal properties, and I can eat whatever I like, and if I take this bar, I'm going to lose weight. That's not going to happen, it's part of the structured program. And with this, I hope I have been able to introduce this topic, which is in keeping with the theme of this particular symposium. We can have questions at the end of the panel discussion. Thank you.